viewers, good day to all of you. This is Dr. BK for you, and today my lecture is going to be on the gluteal region. Now, under the gluteal region, we are going to understand the extent of the gluteal region, followed by how the structures are disposed. So, starting superficially from deep to the skin, we are going to deal with the superficial fascia, structures in the superficial fascia, cutaneous innervation of the gluteal region, followed by we are going to discuss in detail about the muscles present in the gluteal region. So how they are actually disposed in different layers. Then the nerves supplying these muscles and also the nerves which are emerging from this gluteal region, followed by the vessels in the gluteal region, and finally some applied aspects. Now, first of all, if you look at the gluteal region or buttock, it is unique to man. Okay, so why it is unique to man is because of two reasons. One is because we have acquired erect posture, and second one is because we have bipedal type of locomotion. So because of bipedal locomotion and the erect posture in man, what happens is the gluteal region or the buttock region, where we have massive gluteal muscles and abundant fat. Now, if you look at this gluteal muscles, they basically belong to the muscles of the trunk, and but for the functional reasons they are actually present in the lower limb. And why is that? Because for the above two reasons which I have explained it to you. So basically these are the trunk muscles which have migrated to the lower limb because of the upright posture of the man, and also because of the bipedal locomotion. And that is why the muscles are also, you see that massive gluteus muscle in humans. Now, what is the extent of the gluteal region? So the gluteal region does not actually correspond to the extent of the gluteus muscles, but rather above the whole of the iliac crest. So it is limited by the whole length of the iliac crest, and below by the gluteal fold. So that is the lower limit. Now if you look at the gluteal fold, it does not correspond with the lower border of the gluteus maximus, because the gluteus maximus muscle, actually the fibers are oriented downwards and below. So they are sloping or slanting, obliquely placed fibers. But the lower limit is actually a skin grease between your buttock region and the thigh, which runs transversely, and that is considered as the lower limit for this gluteal region. Anteriorly, it is a line extending from the anterior superior iliac spine to the greater trochanter. So that will be the anterior most limit of the gluteal region. And posteriorly, if you look at it, all the sacral spines and the cleft between the two buttocks superficially, which is actually called as the natal cleft. Okay, so again this is only in humans you find the natal cleft. So now coming to the framework, so that is the bony as well as the ligamental framework of the gluteal region. So what are the bones and ligaments which forms the gluteal region? So mainly the iliac crest and the dorsal surface of the ilium. So mainly the iliac crest and the dorsal or the gluteal surface of the ilium, the posterior surface of the body of the ischium, ischial spine, ischial tuberosity and to some extent the ischiopubic rami. So mainly the dorsal parts of the hip bone, to actually simply tell it in a simpler terms. Then you go below, you also have the dorsal surface of the neck and the greater and lesser trochanter of the femur. Okay, the greater lesser trochanter, the neck, of course the head will be present inside the acetabular cavity. Then medially if you come, the dorsal surface of the sacrum and the coccyx. So lateral to medial. So these are all the structures, mainly the dorsal surface of the hip bone, followed by, I told you, the upper part of the femur bone, mainly the dorsal surface of the neck and the greater and the lesser trochanter, the intertrochanteric crust. Okay, so the greater lesser trochanter and the gluteal tuberosity. Then two ligaments you are able to see, the sacrotuberous ligament from the sacrum to the ischial tuberosity. Then other one is the sacrospinous ligament from the sacrum to the ischial spine. So these two ligaments are actually converting your greater sciatic notch and the lesser sciatic notch into a foramen, greater and lesser sciatic foramen. Then also you have the dorsal sacroiliac ligament. So these ligaments support the sacroiliac joint. So that is about the framework. Now coming to the cutaneous innervation. So starting from the skin is actually innervated upper part from before backwards. So the upper part of gluteal region from before backwards, if you look at it, mainly the subcostal nerve or the 12th thoracic nerve. The subcostal nerve or T12 nerve gives a cutaneous branch. Then L1, iliohypogastric nerve. The iliohypogastric nerve gives a branch. Then more posteriorly you come the lumbar nerves, mainly the L1 and L2 nerves. Then you have the posterior rami from the sacral nerves, S1, S2 and S3. Okay. Then if you come below, you see the branches from the posterior cutaneous nerve of the thigh. Okay. So you see the posterior cutaneous nerve of the thigh again from S1, S2, S3 and perforating branches from S2 and S3. Okay. So perforating branches from the S2 and S3 you are able to see here, and a little bit anteriorly you go, you are able to see the branches, posterior branches of the lateral femoral cutaneous nerve. Okay, the lateral femoral cutaneous nerve also you come across. So these are all the branches which is supplying the superficial area, that is the skin and superficial fascia of the gluteal region. T12 iliohypogastric, followed by the lumbar nerves, posterior rami, L1, L2 and sometimes L3 also comes into action. Then sacral nerves through its perforating branches and directly dorsal ramus, S1, S2 and S3. Then you have the cutaneous nerve of thigh, posterior cutaneous nerve of thigh, again S1, S2, S3. And then you have the lateral femoral cutaneous nerve. So if you look at the segments which is supplying T12 to L2, then from S1 to S3, so L3, L4, L5, there is no contribution from the L3, L4, L5. So that is actually the border region. If you look at it, and that corresponds here L4 region in your vertebral column. That L4 segment can be approached for the lumbar puncture. So lumbar puncture is actually a procedure which is done in your spine. You call it a spine according to clinicians, but anatomists we call it as the vertebral column. So highest point of iliac crest, if you take, that will actually corresponds to the L4. So at the level of L4, what happens is, through a procedure you can access the subarachnoid space in the spinal cord. Okay, so spinal dural anesthesia, spinal anesthesia can be given there, or the CSF can actually be withdrawn for some diagnostic procedures. So the superficial fascia, also remember, mainly consists of abundant of fat, and when you look at the distribution of fat in females, generally what happens is it is more as compared to the males, and because of the presence of abundant fat in the gluteal region, that gives a rounded contour for that region. Now coming to the deep fascia, it is nothing but the deep fascia of the thigh, which is actually the fascia lata of the thigh. So the fascia lata of the thigh, it is attached above to the iliac crest, and laterally, it is thickened to form the iliotibial tract, where it is attached to the lateral condyle of the tibia. We have seen well enough of that in our previous lectures. Now it receives the insertion of these two muscles. So posteriorly the gluteus maximus muscle, and anteriorly it splits to enclose the tensor fascia lata muscle. Okay, tensor fascia lata. Then on top of the gluteus maximus, it goes and gets attached to the sacrum. So laterally the iliotibial tract, I told you. Then deep to the gluteus maximus, you also have intervening between this and the medius muscle. You also have another thickening, which is actually called as the gluteal aponeurosis. Okay, so this deep fascia intervenes between the gluteus medius and gluteus maximus as the gluteal aponeurosis. So mainly the deep fascia is actually derived from the fascia lata of the thigh. So now coming to the muscles of the gluteal region, superficially you see two muscles. Immediately deep to the deep fascia, you come across two muscles. The largest or the massive, you see the gluteus maximus muscle, and a bit anterolaterally you see the tensor fascia lata. This is actually the muscle which is present superficially in the first layer. Then deep to the gluteus maximus, if you reflect the gluteus maximus, then you see the next set intermediate group of muscles, gluteus medius, okay, and deep to gluteus medius, or not deep but below the gluteus medius, you see the PIRIFORMIS muscle. Then below the PIRIFORMIS, you are able to see the TRICIPITAL tendon, tendon of obturator internus, gemellus superior, gemellus inferior. Then origin of hamstrings and the adductor magnus muscle from the ischial tuberosity. Okay. So gluteus medius, PIRIFORMIS, and structures below the PIRIFORMIS. I am not talking in detail now, because these structures only we are going to see in the forthcoming slides. Then of course the adductor magnus, ischial part of adductor magnus and hamstring muscles, which we see in the intermediate layer. Then more deeper you go, you come across the gluteus minimus muscle. Okay, so you come across the gluteus minimus muscle, and along with it you have the tendon of obturator externus. Okay, tendon of obturator externus. So tendon of obturator externus is actually more deeper. That means it is more towards the anterior aspect. Obturator externus will go and get inserted into the trochanteric fossa. Okay, so gluteus minimus, and if you go more deeper to the gluteus minimus, you will see the reflected head of the rectus femoris muscle. You see the reflected head of rectus femoris muscle. So we have seen about the muscles which are present mainly in the three strata or three layers. The most superficial layer, the gluteus maximus, you remember that muscle. The next layer, intermediate, you come across gluteus medius. below the gluteus medius you see piriformis muscle and so many structures below the piriformis. And more deeper plane you go, you see the gluteus minimus muscle and tendon of obturator externus, and still more deeper you go, you see the reflected head of rectus femoris. So now we are going to see the gluteal muscles, their origin, insertion, nerve supply and action. So you know that it is a very large muscle and superficial muscle immediately present deep to the deep fascia. It has a very extensive origin from the gluteal surface of the ilium behind the posterior gluteal line. Okay, behind the posterior gluteal line from the dorsal or gluteal surface of the ilium. Then also from the posterior or dorsal segment of the iliac crest, sacrum, coccyx, from the sacrotuberous ligament and gluteal aponeurosis which is present deep to it. Okay. So that is the very extensive origin. Posterior gluteal line, posterior to posterior gluteal line from the dorsal surface of ilium, then all the adjoining areas, dorsal surface of sacrum, coccyx, sacrotuberous ligament, and also from the deeper surface the gluteal aponeurosis. The fibers run obliquely downwards and laterally, and the lower fibers get inserted into the gluteal tuberosity of the femur. Okay, so gluteus maximus insertion into the gluteal tuberosity of the femur. The upper 3/4 fibers are actually getting inserted into the iliotibial tract. Okay, only 1/4 of the fibers inserted in the gluteal tuberosity. The upper 3/4 of the fibers getting inserted into the iliotibial tract. So you all very well know the iliotibial tract. If you trace the iliotibial tract medially, it will get attached to the lateral intermuscular septum, through which the lateral intermuscular septum is gaining attachment to the linea aspera and the lateral supracondylar ridge. So through this you see it is also gaining a secondary attachment, directly not, but through indirectly into the linea aspera and to the lateral supracondylar ridge, that is through the iliotibial tract, and from there via the lateral intermuscular septum. So very strong muscle, that is why it has got very wide attachment. Coming to the action of gluteus maximus, it is a powerful extensor of your hip. Okay, so extension of the hip joint, especially when you are running and climbing. While in quiet standing, the muscle is almost inactive, and in that case the extension of the hip joint is maintained by the hamstring group of muscles. So that is the muscles which are present in the posterior compartment of the thigh is actually called as the hamstring group of muscles. Okay, but this comes into action when you are actually running and climbing. It is a powerful anti-gravity muscle. It regulates the flexion of the hip mainly when you are sitting from the standing position. If you are going to sit from the standing position, then naturally what happens is this comes into action and it regulates the flexion of the hip joint. This is actually called as the paradoxical action. It is actually called as the paradoxical action of the gluteus maximus muscle. Not only that, since it is getting attached laterally, it is a powerful or chief lateral rotator of the hip. Okay, so lateral rotator of the hip, and the upper fibers are also taking part in abduction. Okay, So the uppermost fibers, they take part in the abduction of the hip, and through the iliotibial tract it is maintaining the extension of the knee joint also. Okay, so it maintains the extension of the knee joint via the iliotibial tract. So the actions, as I told you, extension mainly in running and climbing, extension of the hip, regulates the flexion through its paradoxical action mainly when you are sitting from standing position. Chief lateral rotator, through the iliotibial tract it maintains the extension of the knee, and upper fibers are also abductors of the hip. The nerve supply is by the inferior gluteal nerve. So blood supply through the superior and inferior gluteal arteries. Now if you remove the gluteus maximus, what are all the structures present under the gluteus maximus? Now the gluteus maximus, if you compare it, the synonymous muscle in the upper limb is your deltoid. Same way how the deltoid is actually disposed, the gluteus maximus also, because both are very powerful muscle. So there also it abducts, here also it brings about abduction. And the structures under cover of gluteus maximus can be classified into muscles, vessels, nerves, tendon, joints, bony structures, and bursa. So first, more deeper, you come to the deeper structures, the bones and the ligaments. We all know that dorsal surface of ilium, sacrum, coccyx, ischial tuberosity. Then it covers the greater trochanter and sacrotuberous ligament. So that is the greater trochanter, sacrotuberous ligament, ischial tuberosity, dorsal surface of the ilium, then sacrum and coccyx. Okay. Bursa, since it is crossing the greater trochanter to getting into the iliotibial tract, it will be separated between the bone and the bursa, the trochanteric bursa, and sometimes you have the ischio-femoral bursa, or sorry, it is called as the gluteo-femoral bursa or ischio-femoral bursa. So one between the ischial tuberosity and the gluteus maximus muscle. Okay, it is called as the ischial bursa or ischio-femoral bursa. Then you have one more bursa near its insertion, it is called as the gluteo-femoral bursa. So three bursae are present. Muscles, gluteus medius, then deep to gluteus medius you have gluteus minimus. Okay, so part of gluteus medius is cut to show the gluteus minimus muscle. Then you have the PIRIFORMIS muscle. Then below the PIRIFORMIS again you have the tendon of OBTURATOR internus with superior GEMELLI and inferior GEMELLI muscle. Then you have the QUADRATUS femoris muscle and ischial part of adductor magnus and origin of hamstrings. Okay, so hamstrings origin and ischial part of adductor magnus. So these are all the muscles which are present deep to the gluteus maximus. Then apart from that we also have the nerves and vessels. So above the PIRIFORMIS, superior gluteal vessels and nerves. Below the PIRIFORMIS, inferior gluteal vessels and nerves, sciatic nerve, posterior cutaneous nerve of the thigh or posterior femoral cutaneous nerve. Then you have these three structures, the pin structures: pudental nerve, internal pudental artery, and nerve to obturator internus. Okay, so these three structures you are able to see, they are called as the pin structures. Okay, nerve to obturator internus, pudental artery, and internal pudental nerve. So that is about the structures deep to the gluteus maximus: bones, ligaments, muscles, vessels, and the nerves. So mainly intramuscular injections are given in the gluteus maximus. You know very well it is a very large and massive muscle. Now where actually you give the intramuscular injection? In the upper outer quadrant. Okay. So the common site is the upper outer quadrant. You don't prefer the other quadrants because injury. For example, if you take the lower quadrant or lower medial quadrant, sometimes what happens is you might injure the sciatic nerve. Improper injections, if it is not given properly, might lead to hematoma. You know what is a hematoma? So collection of blood at the site of injection. Then abscess might form. Okay, damage to sciatic nerve, already I told you. Then swelling of skin takes place. So this all takes place. Any site of injection, if the injection is not given properly, abscess formation or hematoma and swelling of the skin, slouching of skin takes place. So most common site is, if you divide the gluteal region into 4 quadrants, mainly it is the upper outer quadrant. It is very safe to give intramuscular injections. So we will pass on to the next muscle, which is the gluteus medius muscle, present deep to the gluteus maximus. So that is the gluteus medius muscle, which arises again from the dorsal surface of the ilium between the posterior and anterior gluteal lines. Okay. So dorsal or gluteal surface of ilium between the posterior gluteal line and anterior gluteal line. Behind the posterior gluteal line, we saw all this area, ischio, then sacrotuberous ligament, sacrum for the gluteus maximus, starting from here the whole area. Now here between the posterior and anterior gluteal line, it is the origin for the origin of gluteus medius muscle. It is getting inserted into the greater trochanter, lateral surface of the greater trochanter. So the tip of the greater trochanter is mainly by the traction epiphysis, which is given by the pull of these muscles. Okay. So due to the constant traction or pull given by this tendon, naturally what happens is that tip of the greater trochanter is developed. It is an example of traction epiphysis. Your general anatomy class, 4 types of epiphysis you have: pressure epiphysis, traction epiphysis, atavistic epiphysis, and aberrant epiphysis. Of this, here is an example of the traction epiphysis. Nerve supply is by superior gluteal nerve, which is from L4, L5 and S1. So we will come to the nerves after we discuss about the muscles. The next muscle you see here is the gluteus minimus muscle. The gluteus minimus muscle arises from the anterior and inferior gluteal lines. Okay. So between the anterior and inferior gluteal line, you see the gluteus minimus muscle. So whole extent up till the margins of the greater sciatic notch, the gluteus minimus muscle arises. It is present deep to the gluteus medius, which in turn it is present deep to maximus also. Gluteus minimus muscle again getting inserted into the greater trochanter. Okay, so it is getting inserted into the anterior surface of the lateral part of the greater trochanter. Now, between the gluteus medius and the gluteus minimus muscle, the superior gluteal nerves and the deep branch of superior gluteal vessel, they emerge. Okay. Nerve supply is by L4, L5, S1, that is your superior gluteal nerve. Now all the muscles mainly getting inserted into the greater trochanter, they are actually going to perform the lateral rotation. So the main action of the gluteus medius and minimus, it is very, very important. When acting from above, they perform abduction of the hip. So that is how the abduction of the hip is performed by the gluteus medius and the gluteus minimus muscles. Okay. So acting from above, what happens is they perform the abduction of the hip. Acting from below, so now this part is going to be stationary, and when these fibers are going to contract, when it is going to act from below, it will support the opposite pelvis from sagging down when the foot is off the ground. So for example, if you are standing with this leg on the ground, and if you lift this leg off the ground, then it should support the pelvis from dropping or sagging downwards, and that is maintained by the gluteus medius and minimus muscle. Okay, are you able to clear? Is it clear for you? So unsupported pelvis from sagging down, it prevents the unsupported pelvis from sagging down when that part of the limb is off the ground. The anterior most fibers are again medial rotators of the hip. Okay, the anterior most fibers are the medial rotators. Now, if the gluteus medius and minimus muscle is paralyzed, then what happens is you get a positive Trendelenburg sign, which is actually depicted here. So when the foot is off the ground, the pelvis sags. There is a drooping of the pelvis. Okay, so that is because the gluteus medius and minimus muscle action is lost. So when the person stands on the affected side, the pelvis sags. So you are able to see the pelvis is actually sagging because the muscle is not able to act, and that is called as positive Trendelenburg's sign. So positive Trendelenburg sign means sagging of the pelvis of the unsupported side due to the loss of integrity of the gluteus medius and minimus because of paralysis of this muscle. Okay, this is called as positive Trendelenburg's sign. This, please remember, Trendelenburg's sign and Trendelenburg's test is different. Trendelenburg's test is what we do it for the veins. So positive Trendelenburg's sign. The gait is actually called as the lurching gait in unilateral paralysis. So one side only, if it is affected, it is actually the gait. The person, when you walks, you can see a lurching gait. But it is a waddling gait in bilateral paralysis. Okay, in bilateral paralysis, it is actually called as the waddling. You know what is waddling? So how the ducks they walk. Okay, so that is how you won't be able to lift the foot off the ground. So he will be, what happens is, try to have contact always with the ground, the foot always with the ground. He will try to have contact, and he will just scratch the ground and walk. So that is actually called as the waddling gait. So we have seen about gluteus medius and minimus, its action. So mainly it is the main action we have seen, it is the abductor, and also supports the unsupported pelvis, opposite pelvis from drooping down. The next muscle we are seeing here is the PIRIFORMIS muscle, very key muscle of the gluteal region. Why it is called as key muscle? Because it divides the structures into gluteal region above and below. So it is somewhat present at the plane of cleavage, serves as the plane of cleavage. So from the anterior surface of the sacrum, sacrum is a fusion of 5 sacral vertebra. So from the upper 3 sacral vertebra and the area between the sacral foramina, okay, area between the sacral foramina, it arises at 3 digitations, and also from the capsule of the sacroiliac joint and sacrotuberous ligament, and it is again going to get inserted into the greater trochanter. So these fleshy fibers, they emerge to the greater sciatic foramen. They actually fill the greater sciatic foramen through a rounded tendon. They are getting inserted into the greater trochanter. So nerve supplies by the first and second sacral nerves. Okay, it is by the first and second sacral nerves, It's a lateral rotator of the hip joint. Okay. So piriformis action is the lateral rotator of the hip joint. And not only that, it also to some extent abducts in the flexed thigh. So it is an abductor of the hip in a flexed thigh. So structures above piriformis: superior gluteal vessels and nerves. Below piriformis, I already told you that structures is below the gluteus maximus. So below the piriformis, the tricipital tendon. Then you have the sciatic nerve, medial cutaneous nerve or femoral cutaneous nerve. Then you have the pin structures, then inferior gluteal vessels and nerves. So we are going to see all these structures one by one. Then tensor fascia lata from the outer lip of the iliac crest between the tubercle of the iliac crest and anterior superior iliac spine. Okay, from the anterior superior iliac spine and from the outer lip of the iliac crest inserting into the iliotibial tract, superior gluteal nerve. So it is supplied by superior gluteal nerve. Superior gluteal nerve supplies gluteus medius, gluteus minimus and the tensor fascia lata muscle. So maintains the extension of flexed knee and abduction of the hip, and anterior mostly it is also present. So it is a medial rotator of the hip. Okay, tensor fascia lata. The next muscle you are able to see here is the obturator internus. It actually arises from the lateral wall of the pelvis and around the margins of the obturator foramen anterior surface and from the anterior surface of the obturator membrane. Then it comes out to the greater sciatic foramen where it takes a right angle. You are able to see the fibers taking a right angle, and actually it is going to get inserted into the greater trochanter. Now it passes by a groove which is formed by the superior gemelli and inferior gemelli. So thereby this tendon is separated from the tendon which is present anteriorly, that is the obturator externus. So the obturator externus tendon is separated from the obturator internus tendon by a groove which is formed by the gemelli superior and inferior. Okay. That's what from the obturator membrane and ischiopubic rami and pelvic surface of the ischium. Now, if you look at anteriorly, this will be covered by a fascia, and it is by the pelvic fascia, which is the pelvic fascia, and more laterally, what happens is this fascia forms a tendinous arch of the fascia covering the obturator externus. Okay, on the lateral pelvic wall. Just remember these two, pelvic fascia and the tendinous arch of obturator externus. This we are going to discuss laterally. Later. So insertion into the greater trochanter, and that is what I told you, mostly into the medial surface above and in front of the trochanteric fossa. So nerve to obturator internus L5, S1 and S2. The next muscle is the gemelli muscle from the spine of the ischium. It joins with the tendon of obturator internus along the upper border or upper margin. Gemellus inferior from the lower border of the lesser sciatic notch joins along with the lower margin of the obturator internus and again getting inserted in the same place along with the obturator internus tendon. So superior gemelli is supplied by nerve to obturator internus, whereas inferior gemelli is supplied by the nerve to quadratus femoris. So I told you they form a muscular groove for the tendon of obturator internus, thereby it separates from the obturator externus tendon. So the next muscle we have seen is these three tendons called as the gemellus superior, tendon of obturator internus and gemellus inferior. These are actually called as the short lateral rotators of the thigh. Okay. So the chief lateral rotator we have seen about the gluteus maximus muscle. This is actually short lateral rotators of the thigh. Mainly they bring about lateral rotators in a flexed hip. So the best example to give you is when you put your leg outside in getting out of a car. Okay, this is a very classical example to describe the action of these short lateral rotators. So that is your gemellus superior, obturator internus, and gemellus inferior. And not only that, even the quadratus femoris has got a similar action. It is called as quadratus femoris because it is quadrilateral in outline. From the ischial tuberosity, outer surface of the ischial tuberosity, inserting into the quadrate tubercle of the femur. Okay. Now, if you look at the quadrate tubercle, it is present somewhere in the midway between the intertrochanteric crest, that is between the greater trochanter and the lesser trochanter. And because it is a projection and this muscle is getting inserted into the quadrate tubercle, don't think again quadrate tubercle is because of traction epiphysis. It is not because of traction epiphysis. It is actually the fusion of epiphysis between these greater and the lesser trochanter. So nerve supply is by nerve to quadratus femoris. The root value is L4, L5 and S1. And it is again a short lateral rotator of thigh or hip. So we have finished about the muscles, mainly the gluteus medius, maximus, minimus, piriformis, obturator internus, tensor fascia lata, superior gemelli, inferior gemelli and quadratus femoris. So now we are coming to the nerves of the gluteal region. Superior gluteal nerve, dorsal division, ventral rami, L4, L5 and S1. Emerges between the gluteus medius and minimus and mainly supplies the gluteus medius and minimus muscles. And the tensor fascia lata, it supplies superior gluteal. Emerges above the piriformis to the greater sciatic foramen and branches to these three muscles I told you, and also gives an articular branch to the hip joint. It does not give any cutaneous branch. Inferior gluteal nerve emerges from the lower border. This is from the dorsal division of ventral rami of L4, L5 and S1. From the lower border of piriformis, again from the greater sciatic foramen, it is going to supply the gluteus maximus muscle. It takes a recurrent course and it will supply the gluteus maximus muscle from the deeper surface. Accompanied by inferior gluteal vessels, that is about the inferior gluteal nerve, supplies only the gluteus maximus muscle. Sciatic nerve, I am not going to describe the whole nerve because that I will be doing it in the posterior compartment of the thigh. Here, thick nerve, largest 2 cm wide, arising again from the greater sciatic foramen from the lower border of the piriformis muscle. Root values L4, L5, S1, S2, S3. It has got two components. It has got a tibial component and it has got a peroneal component, and lies on top of these tricipital tendon and separated from it by the nerve to quadratus femoris. Actually, immediately deep to it you see the nerve to quadratus femoris. Above it sometimes you see posterior femoral cutaneous nerve, or it is present medial to it. Then it passes deep to the long head of biceps femoris. Okay, does not give any branches but divides into tibial and common peroneal at a variable distance from the popliteal fossa. So that is about the sciatic nerve, thickest nerve. Root values L4, L5, S1, S2 and S3. The next, posterior femoral cutaneous nerve, you are able to see, it is also called as the posterior cutaneous nerve of thigh. So dorsal branch of S1 and S2. Okay, so L5, S1 and S2. Its contribution is also L5, S1 and S2. Below the piriformis, present medial to or sometimes posterior to the sciatic nerve. So descends in the back of thigh and gives gluteal branches. It is a cutaneous nerve, gives gluteal branches. It also gives, that is to the skin of the gluteal region. We have seen the lower part of the gluteal region. S1, S2 and S3. So Sometimes it pierces the sacrotuberous ligament, but it passes into the perineum and supplies the skin over the labium majus in females and scrotum in case of males. So, through the colles, fascia and all, it is going to supply this perineum. Now, parasympathetic innervation of the perineal organs are again S2 and S3. So, referred pain from this perineal can also be felt over the posterior femoral cutaneous branches, because it supplies and it is sharing the same segmental nerves. Okay. Then the remaining branches, perforating branches, actually supplies your lower part of the skin of the back of the thigh and upper part of the leg. Okay. So, it gives gluteal branches, perforating branches and perineal branches. Posterior cutaneous nerve. The next nerve you come across is the nerve to obturator internus. So, here you are able to see the pin structures. Then the nerve to quadratus femoris. Both arises below the piriformis from the greater sciatic foramen. The former one supplies the obturator internus and superior gemelli. This one supplies the inferior gemelli and the quadratus femoris, and the nerve to quadratus femoris again gives an articular branch to the hip joint. Okay. So, nerve to quadratus femoris supplies quadratus femoris, inferior gemelli and gives a articular branch to the hip joint. So, nerves, we have seen superior gluteal nerve, inferior gluteal nerve. Then we have seen in short about the sciatic nerve, posterior femoral cutaneous nerve, nerve to obturator internus and nerve to quadratus femoris. Blood vessels, superior gluteal artery. So, from posterior division of internal iliac artery, superior gluteal artery, emerges above the piriformis, divides into superficial and deep branch. So, unlike the nerve which does not divide into superficial and deep branch, here it divides into superficial and deep branch. The superficial branch is muscular and supplies the gluteus medius and minimus. The deep branch is going to take part in the anastomoses, mainly your cruciate anastomoses, okay, and the spinous anastomosis. So, take part in the spinous anastomosis and also the anastomosis around the greater trochanter. That trochanteric anastomosis, superior gluteal artery from anterior division of from the posterior division of internal iliac artery. Inferior gluteal artery is actually from the anterior division of the internal iliac artery. Inferior gluteal artery. So, below the piriformis, muscular branches, it is mainly going to supply the surrounding muscles and especially your gluteus maximus muscle. Then it takes part in the trochanteric anastomosis and cruciate anastomosis. Internal pudendal artery, again anterior division of internal iliac artery below the piriformis. So, the pin structures, it is a part of pin structures, internal pudendal artery. Okay. So, below the piriformis and it is related to the ischial spine, lying on top of the ischial spine, then it will pass via the lesser sciatic foramen, then it will traverse the pudendal canal in the perineum. Okay. So, enters the pudendal canal via the lesser sciatic foramen and it will traverse the pudendal canal in the perineum and it will supply the structures in the perineum. Same way I have not discussed about one more structure, that is the pudendal nerve. So, that is also going to supply the perineum. Pudendal nerve and pudendal artery, internal pudendal artery, so does not supply any structures in the gluteal region. So, that is why I will not be discussing about that, but just you should remember they are present, appears as a short course here as spin structures. From the greater sciatic foramen they emerge, it is present on ischium and immediately they travel to the lesser sciatic foramen to enter the perineum. So, the trochanteric anastomosis chief supply to the head of the femur. Here you are able to see on the greater trochanter the trochanteric anastomosis. It is formed by the descending branch of superior gluteal artery. So the superior gluteal artery will give a descending branch, ascending branch of medial circumflex, sorry for the spelling mistake, it is actually the medial circumflex, then ascending branch of lateral circumflex. So ascending branches of lateral circumflex and ascending branch of medial circumflex, and also a branch from the inferior gluteal artery. So branch from superior gluteal, inferior gluteal, and ascending branches of the medial and lateral circumflex artery. That is called as the trochanteric anastomosis. Here you have spinous anastomosis, which is again formed by like descending branch, ascending branch of superior gluteal, branches from superficial and deep external pudendal artery, and branch from iliolumbar artery. Branch from iliolumbar, branches from superior and superficial and deep external pudendal, and ascending branch of superior gluteal artery, all forms the spinous anastomosis. This is trochanteric anastomosis from ascending branches of medial and lateral circumflex, from superior gluteal and from inferior gluteal. And finally, we have the cruciate anastomosis. So the cruciate anastomosis is mainly formed by the transverse branch of medial circumflex, transverse branch of lateral circumflex, inferior gluteal artery from above, and ascending branch of first perforating artery from below. Okay, so descending branch of inferior gluteal and ascending branch of the first perforating. So they take part in the cruciate anastomosis. Now, the trochanteric anastomosis is actually a collateral circulation between the femoral branches of femoral artery, that is from the profunda femoris of the medial and lateral circumflex, superior and inferior gluteal from the internal iliac artery. So if there is an interruption of the blood supply when the femoral artery is damaged or cut or occluded, then naturally blood can reach via this, mainly the trochanteric anastomosis, because it anastomoses with the internal iliac artery. So that is, we have seen about the blood vessels. Piriformis syndrome. So what is piriformis syndrome? Compression of the sciatic nerve by the piriformis, because it arises in the lower border of the piriformis. So naturally this, sometimes the muscle fibers can put pressure, so pain and numbness in the buttock and along the distribution throughout the leg. And when you sit, naturally the compression is going to be more and the pain worsens while you are sitting. So that is called as the piriformis syndrome. The main cause is due to trauma, any injury or spasm of this muscle, or overusing of the piriformis. They are all short lateral rotators. No? So when you overuse of these muscle or trauma or spasm might actually lead to compression of the sciatic nerve. So with this, I am completing the gluteal region. Thank you for your patient listening. We will meet again in one more lecture.